now this is the oxyhemoglobin curve that I was talking to you guys about, right? So as I said, make this a little bit smaller. Here we have the partial pressure, right, of oxygen, right? This is and here on the side I have saturation. So saturation is like I put a probe on your finger and I'm going to measure, right, how much oxygen is there. We know normal is 95 to 100, right, for a healthy person. Here you see, right, at this graph, right, if I'm here, I have my PaO2, the pressure is 100 and my saturation is 100. Now as I'm going to the tissues, right, you notice this graph is not as steep. It's slow decline, slow. But the moment I get to here, it's like plummets, right? Plummets very fast. And right. So what is occurring here? So what is occurring here is at the tissue level at about 40, right? At the tissue level about 40, right? The tissues extract that oxygen. And as I said, right, the way hemoglobin works, if I'm taking 1 out of the 4 units, then the remainder is more easily given off. So I'm able to give this off, right? At this point, I'm only 70% saturated, right? And I'm gonna go back to the lungs, and I'm gonna pick up more oxygen, right? Now in the lungs, if oxygen is abundant, present, it's gonna go there. It's gonna pick up more O2, and the cycle is gonna repeat, right? Now, some things do shift hemoglobin, right? So you notice, right, if I'm becoming more acidotic and my pH drops, so let's say I go from normal is 735 to 745, right? So if I go from 7.4 to 7.2, I became more acidotic. And what you notice here is here. So let me make this up. If I became more acidotic, right? So the curve moved to the right. So it moved from the normal to the right. At this movement to the right, is my hemoglobin holding to the oxygen more or less? Less. And the reason why it's holding less is because when you have increases, or when you have decreases of pH, which corresponds to increase of hydrogen ion, right? That will basically shift the hemoglobin to get rid of its oxygen. It will make the hemoglobin unload, right? So if we had, let's say, a carrier of 4 oxygens here, right? O2, 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 O2. And as I get rid of one and I have buildup of hydrogen, it will facilitate bigger and bigger removal of this. On the other hand, if I move my hemoglobin, if I move my curve to the left and I make it more alkalotic, right? I can do this by squeezing the bag faster, by getting rid of your CO2, right? It's gonna make my hemoglobin into more of a tense state, and the tense hemoglobin holds onto oxygen more stronger, even though it's more saturated, right? But it does not want to get rid of the oxygen. So what happens is you will need to drop the pressure more for it to get the same amount, right? The same amount. So so the same goes. So pH, right, can affect it, and so can the temperature. So the more cold you are, hypothermic cold will keep it stronger on, versus if you become warmer, right, it will not get rid of the oxygen more. So what actually happens, right? Let me show you on this scale so you could see, right? So this portion here, right, of the hemoglobin, as you add the protons to it, right, what happens is it switches this hemoglobin and stabilizes this tense state, and it wants to get rid of all the oxygen that it carries. So by stabilizing this tense state, it will basically further unload. Now, this is just a summary of all the shifts, what causing a left shift versus opposing what causes a right shift. So a right shift will give up more oxygen, and the cause of it is high CO2, high hydrogen ion, or lower pH. So more hydrogen ion will lower the pH, more 2,3-DPG, that's a substance found in your blood, and high temperature. And the left shift will hold onto oxygen more tightly, will not want to give up oxygen. And that's caused by reduction of CO2, reduction of hydrogen, reduction of 2,3-DPG, reduction of temperature, and fetal hemoglobin. Fetal hemoglobin holds onto the oxygen more tighter. So let me just go back into a graph so I can kind of like maybe make this a little better so you guys can see. So let's I'm just gonna take I'm gonna say this was saturation. So remember we said this portion of the graph shows you how much oxygen is how much percentage of hemoglobin is saturated. Let me just pick a random number. Let me just say 60. Let me draw a straight line. Right. So at this point, right, 60% of the hemoglobin is saturated. That means that 40% has were given off. And then where these lines meet, I'm going to go straight down. I'm going to go. Let me take a different color. So I'm going to go down here. Right. I'm going to go down here, and I'm going to go down here. So what you notice is this. If I want to see which pH, right, at what pH it gives out the most amount of oxygen, you notice that for this graph, right, at 7.2 pH of 7.2, I gotta get a partial pressure of 40 to get saturations of 60, right? For the second one, I gotta get to 30, right? And for here, I gotta get to 20. So you notice here, I have much less drop of the pressure in order to achieve the same saturation. Here, I gotta drop the pressure way more in order to get the same saturation. It's much easier to achieve higher pressure, right? So that's why at a higher pressure, it gives up more oxygen as you move to the right side of the curve, as opposed to going to the left side of the curve. It holds onto oxygen more tighter, right? So now that I showed you all this, right? So we talked about the right shift, left shift, right? And what causes these things, right? Here. One thing that you can control as a paramedic, right? You arrive to a call to pre-oxygenate a person, right? You want to intubate them. And let's say you determine that failure to oxygenate, they cannot protect their airway. And you start to bag them, right? You put the bag on and you start to bag them. And you notice, right, your set is not really improving right away. So you say, you know what, let's just bag them faster. Let me just hyperventilate them. One breath every 2 seconds, one breath, every second, right? So we said, if I do that, what my action of squeezing the bag once every 2 seconds is gonna do to the PCO2? Is it gonna go up or down?
Down.
It's gonna go down, right? So we all said that. So if my PCO2 goes down, I'm gonna get a left shift on this curve. So that means my curve moves this way, right? So if I squeeze the bag faster, my curve moves this way because my PCO2 is going down. That means the hemoglobin holds to oxygen more tighter, or it wants to get rid of oxygen?
More tighter.
More tighter, right? So is that good for a patient who is, let's say, not breathing adequately, let's say who is in respiratory failure? Do I want his hemoglobin to hold the oxygen more tighter?
Yes.
Yes.
So if my hemoglobin holds oxygen more tighter, do you think it's going to get that oxygen unloaded at the tissues or not? So if the hemoglobin holds them tight, no, it won't, right? So if the hemoglobin holds the oxygen more tighter, there's less of it that I want to unload. And why? Because I just showed you on this graph. Remember, we said if I squeeze the bag faster and I increase my pH because there's more CO2, I gotta get to much lower pressure to achieve the same saturation. I gotta drop my pressure way more in order for it to get rid of oxygen. And we said our pressure in the tissues is 40, right? I showed you the picture. It said 40, right? So at the pressure of 40, do you think it wants to give off? It doesn't. It wants to hold it. You see, it only starts to dissociate when we get to this 20 pressure. So at the pressure of 40, is it dissociating? No, it's not. It's holding it. So what's the problem with this, right? So the problem with this is that this aggressive ventilation, right, for your pre-oxygenation, you're not actually helping the patient. What you're actually doing is you are making sure his hemoglobin holds to oxygen tighter, and he's not going to get any oxygen. So let's say he's not breathing. That hemoglobin passes first run through the lungs, it gets loaded with oxygen, goes to the tissues, and you keep squeezing the bag faster and faster, right? And that hemoglobin holds to the oxygen more tighter and tighter. And that hemoglobin goes to the tissues, and the tissue cannot extract oxygen from hemoglobin, right? You basically creating a worse and worse condition for the patient because his tissues are no longer able to use oxygen, right? Does that make sense?
Yes, but I have a question.
Yeah, go ahead.
If the patient's acidotic to begin with,
Yeah,
and you hyperventilate them, so that could be a good thing, right?
so if the patient is acidotic, so it depends. So if I want to pre-oxygenate them for intubation, right, that may not be a good thing because they may be acidotic and their state, they need that so that more oxygen gets unloaded. So imagine you have this patient who, for whatever reason, was acidotic, and his tissues, let's say septic patient, and his tissues was aggressively using all the oxygen it could extract. And then I start to hyperventilate him, and then I do this to him. So does hemoglobin wants to give up oxygen now?
No.
No. So my hyperventilation caused hemoglobin to hold to oxygen tighter so that his tissues are no longer seeing that oxygen. Even though hemoglobin is more saturated with it, has more oxygen bound to it, it's not unloading. So that is something you don't want to do. I'm going to explain to you what you do want to do once we get to those slides there, right? So this is just a couple of concepts if you see them in your book to understand. So you may have a right shift, right, to move this hemoglobin to the right. It's called Bohr effect. So high CO2, so more protons and more acid, right? Acid will move the curve to the right, right? And if you get rid of CO2, right, if you blow off CO2, it's going to move it this way. This is a Haldine effect. It's basically you could get more CO2 bound to the to your hemoglobin at the lung tissue. I wouldn't worry about these two concepts. What I want to get to is the next portions of the slides. This is 2,3-DPG. I showed you. Let me just explain this. What is 2,3-DPG, right? 2,3-DPG is found in your blood all the time. It's basically a byproduct of glucose metabolism. So when you take glucose, right, it breaks up all the way down, right, into pyruvate, goes into the Krebs cycle, right? You don't need to know all the details, but there's an enzyme called basically diphosphoryl mutase that basically converts 1,3-DPG into 3-DPG. DPG is the same thing as BPG. The whole point of the slide is, what is this thing? It's in your blood. It's there all the time. The more of this you have, the more it shifts the curve to the right. So it's good. It's going to get rid of the oxygen. This molecule, you do not, fetal hemoglobin doesn't have it. That's why fetal hemoglobin binds oxygen more tighter, right? This is just the only thing here. But this is what I want to get to you, right? So because you notice, right, this hemoglobin dissociation curve, right? Not only if you aggressively squeeze the bag, you're going to shift it to the left. The other important thing is here you have time, right? So here you have time. What do you think happens at this point? What do you think happens to this point, to the oxygen?
It unloads.
Unloads, right? Unloads. So think about this. Think about the following. I pre-oxygenated my patient, right? Let's say 200%, and then I'm taking way too long. Let's say it's taking me like several attempts, and if I'm looking at my sat, it's dropping, right? I now look at my monitor, my saturation. Let's say I'm here. Let's say it's 90%, and you say, like, listen, I see the vocal cords. I'm about to intubate, right? I'm about to intubate, and you keep going. And what do you think happens here? Your hemoglobin gets unloaded fully. And now, if the patient is not breathing or has respiratory failure and you're not bagging the patient, do you think as this hemoglobin travels to the lungs, can it pick up more oxygen?
No.
No. So your tissues become anoxic. It's the same thing for the brain, right? Your brain becomes anoxic. So that's how these patients develop anoxic brain injury, right? So why do I have this slide here? So the reason why I have this slide here, right, is from 100 to 90% saturation, right? It's relatively long time because the curve is not steep, right? But the moment you reach 90% on your saturation, the curve is very steep. The desaturation of hemoglobin is excessive. So it means you can go this from here to here could be 4 minutes. From here to here could be seconds. And not only seconds, it could be even less than that for a sick patient. So why do I bring all this up? Why do I stress this oxyhemoglobin curve? Why is this important for intubation? Can anyone tell me after what you heard?
The amount of time it takes you to intubate, depending on how much oxygen saturation you start with,
Yeah,
could be critical.
exactly.
So yes.
Yeah. Keep going.
Yeah.
Yeah,
Okay.
keep going.
So like if so you got to really make sure that you get the tube in place in time, and if not in place in time, you got to back out, pre-oxygenate.
Excellent.
could
So
cause-
let's say that's what I'm saying. Let's say I'm starting to hit 90%, or maybe I got 89, right? But I kind of see the vocal cords. Should I keep going?
No.
No, you should stop, and you
No.
want to bag
I'm
him back to
breathing.
100. And the reason why is that in the mere of 20 seconds, you can go from here to all the way being at 30, and your patient can code. Your patient can go into cardiac arrest. I have personally seen during my times working in the hospital and being on rotations, I seen a lot of patients who got killed because of this, of junior residents not understanding these concepts, right? So for your purposes, right, I want you to ingrain 90% saturation, right, as the cutoff, right? Now let me ask you this: from, let's say, you using excellent technique, two-handed technique, you pre-oxygenate your patient, right, to 100%. How much time do you think you got to get to 90? Let's say you have a patient who is relatively healthy.
30 to 45 seconds.
30 to 45 seconds. So truly speaking, you have minutes. You have 4 to 5 minutes, right? So in the lab, when we do skills, they're going to stress to you guys, intubate 30 seconds, intubate, right? And all of that was essentially to prevent this portion of the graph. But I want to I don't want to tell you misinformation. I want to tell you the real information. And so you guys understand this and you apply this properly. So if you pre-oxygenate well, use two-handed technique, not one-handed technique, and you denitrogen the lungs, because we said it's 79% nitrogen. I'm going to do 100% oxygen with my BVM. I want to do full nitrogen washout. I'm going to connect it to my end-tidal CO2 detector so I know that every breath is going in, and I want to keep my end-tidal CO2 35, 45. If I pre-oxygenate this patient to 100%, right, I have 4 to 5 minutes wiggle room. But what you must be critically important to keep in your mind, the moment I start hitting 90%, and for you guys, I'll probably get to 93%, maybe 92%. You stop what you're doing. You stop what you're doing, and your next action is to put back the OPA or NPA or whatever adjunct was, and you go back to 200 ventilation until this number is back at 100. Because here we can work. Here you have a dead patient, right? So that's why it says brief moment here, and you have relatively long time. So I have this monitor. This is a LifePack 15, right? So when you are about to start your intubation procedure, right, knowing what you know about the oxyhemoglobin dissociation curves, right, as you are intubating, you as an intubator, as the operator, right, you should have a full view of the monitor. The monitor should not be somewhere at the side of the patient's legs where you cannot see it. It should be at the point where you are seeing it, right, when you're going to intubate. The numbers that you want to be attentive to is this number, right, and this waveform. If the waveform is present, I know I can trust this number. It says 99, right? So I'm looking at this number. And as I'm doing my procedure, right, yeah, I am looking at the airway, but I'm also constantly scanning, right, my saturation level. And the moment this starts to drop down, right, and you hear it, right, 94, 92, 93, right, you should at 90, right, 90 should be like your minimal cutoff. You stop what you're doing, and you pre-oxygenate the patient back up to 100%. This is one of the most neglected things that it's not done. The other important thing we talked about, right? We said if we squeeze fast, right, the CO2 will drop. If I squeeze back fast, aggressively, my CO2 will drop, and that makes my hemoglobin hold to oxygen more tighter, and then the tissues are not seeing that oxygen, right? So this is another important concept. So that I do not want to squeeze my bag every 2-3 seconds, and this notion of hyperventilation, you should remove that from your vocabulary when you're intubating. The term should be pre-oxygenation, right? And what I want to do is I'm also looking at this number. I'm connecting my EtCO2 detector to my BVM, and I'm looking at this number. I want to keep this between 35, 45, and I'm looking that I'm getting good waveforms. I don't really care the rate. So if I place my patient on a BVM and I start to ventilate and I connect my connector, and I see that for him is normal, right? I gave 1 breath, 2 breaths, I see it's 35 for him, I'll maintain this number. So I'll squeeze my bag to maintain that number, right? I don't want to slow down to make it 45. The reason why, maybe this patient is compensating for something else that's going on in his body, and I don't want to remove that compensation. So when I connect my BVM and I see it's 35, I'll maintain that, and I'll squeeze this bag to get my waveform. And I know if I have a waveform, my breath went in. So this is real time. Pulse ox, you may have a pulse ox lag. So that means that if a patient is sick, right, his cardiac output is not as robust, this may lag. So you will put a pulse ox, you won't see it right away, right, start to come up. It will take some time, right? Or if you put it on the cold hand, you'll see it take some time to read. Same thing when the patient starts to desaturate. That means that, truly speaking, if you really want to know why I tell you 92, 93, right, is because of this pulse ox lag in real time, they may already be at 88 because this number is behind. So 92, 93, you stop what you're doing and you start to bag. But 90 should be a hard cutoff. Do you guys understand what I'm saying? Any questions here? This is clear?
Clear.
Clear. All right. So this is, you guys told me, right? I asked you how much time you got. This was a study they did in anesthesia literature. They basically, what they did, they took normal healthy adult, and they took a child, and they took an obese patient, and they took ill patient, and they gave them succinylcholine. That's medication. It's basically paralytic. It will paralyze your muscles. It'll paralyze your diaphragm. You stop breathing. And what they did is they took them to anesthesia room. They pre-oxygenated them to 100%, right? The sick guy, they could not pre-oxygenate to 100. They could only get it to this level, maybe 94%, right? So you notice, right, for a normal adult person, if you are at 100% saturation, right, it will, to get to 90, it almost, took 8.5 minutes, right? 8.5 minutes for a moderately ill 70-pound person, right, to get to 90%. It took 5 minutes. For a child, right, 90% was less than 4. And for an obese person at 90%, right, obese person was like 2.5 minutes, let's say. So the reason why these numbers are important kind of gives you an idea, ballpark. If you pre-oxygenate your person well, if you get them to 100%, right, how much time you got until that critical desaturation. Now, what happens is you got a sick person, you put them on a pulse ox, right? And to begin with, they are setting 89%. And you say, you know what, they need to get intubated. I'm going to go straight to intubation. I'm not going to even bother with pre-oxygenation. What's the problem with that?
They're already not perfusing correctly with the oxygen. So,
exactly.
Yeah.
So they will, your attempt will cause them to desaturate so quick that they will most likely suffer cardiac arrest. They will basically desat, they're 89 and you don't pre-oxygenate them, they will go down that curve and they will have anoxic brain injury or worse, cardiac arrest and death. So the purpose of all this is that you want to use, right? Don't use one-handed EC clamp. That's the worst technique you could use. When you're pre-oxygenating, put the adjuncts, right? OPA and an MPA. If the patient can accept OPA, I put both OPA and PA. You put a high flow nasal cannula, right? So that the nasal cannula is flowing through the patient passively. You're going to connect your end-tidal CO2 detector to the BVM. You're going to use two-handed technique. Two-handed technique means one person is holding the mask in place, the other person is squeezing, and I want to get that to 100%. I want to get it to 100%, and I want to actually do it for a few minutes longer. Why? Because not only do I want it to be 100%, I want to get rid of all the nitrogen. I want to get nitrogen washout. I want to get 100% oxygen, right? And I want to get my hemoglobin fully oxygenated, and I want the delivery to the tissues to be optimal, right? Once that is all completed, right, I'm going to place them on the I see my monitor. You're going to learn skills, but the reason why I have this is that we learned the anatomical landmarks, right? Your oral axis, right? Oral pharynx, your pharyngeal axis, the pharynx, and the laryngeal axis. And for you to get the optimal view, you want to align all these axes. For an adult person, what you're going to do is you want to position them, right, with ear hole to the sternal notch. So you're going to put some tissue, you're going to put some padding, some blankets back of their head, and then you're going to open the airway. Here you see all the axes is aligned. This will give you the optimal view of the vocal cords that we saw in the initial picture. This will not give you optimal view because these axes are not aligned. Once you have them aligned, right, this is what I mean. This is, if you intubate your patient in this position, ear is not aligned to the sternal notch, you will not get oral axis, pharyngeal axis, and laryngeal axis in the proper locations. In this position, right, you notice that the ear hole is aligned to the sternal notch. This is for those patients who do not have cervical spine injury. Once we do trauma, you will see the technique there. But this is for the patients who do not have trauma, no cervical spine injury. How will you get to this position? So one thing you can do is you could use your stretcher. You notice they put some padding, right? So ear to the sternal notch, right? They put some padding, so you could use your stretcher, elevate it slightly up. Here they use the bunker gear and some fluids, right? So ear to sternal notch. Doesn't matter what you use. What's important is you get this position. You don't get this position, you're not going to be able to visualize your vocal cords. You're going to take too long to intubate. Your oxyhemoglobin desaturation curve is going to drop. So this is the positioning. Next thing you're going to do is how you're going to position. So this position, the way he is in, is not bad. He's able to move his elbow, right? So to instrument the airway. So this position is good. He got the padding, so he got the ear to the sternal notch here. So that's fine. This position you can do. I'm not too fan of this, but he could still at least move his elbow, right, to open the airway. This position is don't do this position. His elbow is grounded on the ground. It'll be very hard to lift the mandible. You basically will not have enough leverage to do it, right? So this position is not the best. This you will often see medics do. Do not personally, I advocate for this. The problem with this position is they're trying to get this ear hole to the sternal notch. I've been on calls where some medics try to do this. I do not like it because they're not always able to stabilize the patient right. The head is moving about and you have no control. The other thing is, you notice, right, he's holding his tube is already in his hand. I want the other hand free to open the mouth. I got to use my cross finger technique because most patients don't come with the mouth open, ready to get the tube in their mouth. And I may need to suction, right? And I may need to take, my time with the BVM to pre-oxygenate. So this is very bad thing to do. I know medics do it. I advise you don't do it. So place the stuff there, right? I kind of talked about, right, the respiratory centers in the brain. So here, right, the specifics that we talked about is the control of hydrogen ion, right, and the pH that drops that controls the increase, right, of your respiratory drive. So you'll breathe faster for that. The higher centers, right, certainly in the cerebral cortex, the limbic system, right, hypothalamus is the control center. And the relays are going down to the medulla. And here is where the CSF is sensed with the hydrogen ion. And that's basically the pH and the hydrogen ion controls, right, the frequency of your ventilations. So do I need to increase my ventilation? Do I need to decrease my ventilation? So that's the major component of this.